Hey everyone, this is Dr. Zach Greenwade here at Performance Sport and Spine, and today's video we'll be discussing shoulder impingement. Shoulder impingement is the most common condition affecting the shoulder and commonly presents as anterior lateral shoulder pain and made worse with overhead movements. So now we're going to talk about how to diagnose this condition. So the first thing is a good clinical history and physical exam. Now this should rule out the cervical spine, the thoracic spine, and any vascular issues. And also, no one single test is helpful, but it has found that a clustering of tests can be helpful. So the Hawkins-Kennedy, the painful arc, and the infraspinatus muscle test, if all positive, increases the likelihood that this condition is what the person has. So routine imaging is not recommended. If the person has persisting pain or symptoms at 6 weeks, ultrasound is the preferred option due to the cost effectiveness of it and the clinical utility. So the reason routine imaging is not recommended is that people often have the expectation that they want to take an image to find what is the cause of their pain. But the problem is this problem is more complicated than that. So if the person is told that there's a bone in their shoulder wearing out their tendon, they're going to believe that surgery is probably their only option. And I have to say, working in the clinic and seeing a lot of these conditions, it's very frustrating to hear a lot of people get poor and outdated medical advice and suffer unnecessarily. So for Prognosis, about 60% of people will experience improvement within 3 months. However, 40 to 50% of people will still experience some amount of symptoms at 1 year. And factors that can decrease your prognosis is psychosocial factors, being the age of 45 to 54, and having symptoms prior to 3 months before starting treatment. So now we're talking about different treatment options. NSAIDs can be used for acute pain. For this should be used for only about 2 weeks. Corticosteroid injections can be used, but this is a case-by-case management for pain. And then manual therapy can be used, but if it is, it has to be used in conjunction with exercise. Now we'll discuss initial phase exercises. So for these, the load should be light, the set should be 2 to 4, reps should be about 10 to 15, and the frequency should be 4 to 6 times a week. Now, however, these are general parameters and you will always need to tailor it to the individual. So some discomfort is normal, but the pain should never exceed a 4 out of 10. If it does, you need to do things to decrease the different variables such as less weight, less reps, less range of motion, or longer rest periods between exercises. Supine external rotation. On your back with your elbow at 90 with a light weight in your hand, you're going to slowly lower your weight of the hand down towards the floor, again pivoting to the shoulder. Now you may need to initially reduce your range of motion and increase it over time as the shoulder is tolerant. Again, there should be a very light weight, and you want to rotate through the shoulder, feeling a gentle dull tension through the back of your shoulder. Seated external rotation. Have your arm placed on an object with your elbow at 90 and rotate through your shoulder, your hand up towards the ceiling, and down again controlled. Again, you should feel some gentle dull tension in the back of your shoulder, and the weight should be very light. Sometimes you may need to adjust the range of motion and not go up all the way or down the way initially, and over time increase it. Table slides. Sitting on the ground with your hand on a table or a bench, slowly press your arm outwards to tolerance, extending up and away from your head. Now again, your hand should be relatively rested and you're just pressing up with your shoulder joint. Sometimes initially it will help to decrease the range of motion and only press up partially, and then over time increasing the full length. Rotation. So lay on a bench with a very light weight in your hand with your arm at 90 and rotate your hand upwards towards the ceiling. Again, keeping that elbow at 90. And again, the weight should be very light and you should rotate through your shoulder and not just bend your elbow or your wrist. Wall slides. Stand against the wall with one hand placed on the wall and gently press your hand up towards the ceiling to tolerance and return. And again, initially you may need to reduce your range of motion, and then subsequently as the shoulder calms down and you feel stronger, increase the range of motion until you can get fully extended. Banded wall slide. Place a light resistance PT band between your hands. Place your hands against the wall with your elbows at 90, pressing gentwards outwards with your hands into the band, and press your hands up towards the ceiling to tolerance. Again, you may need to limit your range of motion initially, and then as your shoulders calm down and get stronger, you can increase the range of motion in subsequent exercises. Again, the goal is to get your hands to be fully overhead with external pressure on the band. So we got to go way back to 1983 where Dr. Neer, a famous surgeon, coined the term shoulder impingement. He theorized that the soft tissues of the shoulder, i.e. the bursa and tendon, were getting mechanically compressed or irritated by the bony structures of the shoulder. So Dr. Neer stated that 95% of the cases could be explained by this mechanism, and subsequently wrote a paper. Now the problem was this paper wasn't very well done, and it was really more of an opinion piece, but it shaped orthopedic care of this issue for the next half century. So it turns out this issue is not quite so straightforward, and we'll go over some research that challenges this theory. So Dr. Neer's theory, the superior part of the tendon should get irritated by the chromium as it's above that. But if you look at these two papers, they found that 70 to 80% of the time it's the inferior or the bottom portion of the tendon that's getting irritated or impinged on. Secondly, the chromium actually had three different types. There's type 1, type 2, and type 3, and type 3 is more hooked. So the theory was the more hooked your chromium was, the more likely that it would impinge or irritate your tendon. But from these studies, we see that there's no or very poor correlation for that. Let's say there was a rotator cuff tear. This paper showed that there's a high prevalence of people that have no pain at all, there's no symptoms, but they still have a tear. And then this paper showed that there was a very similar percentage of people that had rotator cuff tears with people that were in pain and without pain. So based off this research, we need to change the name from shoulder impingement to something more like subacromial pain or rotator cuff related pain syndrome. So lastly, we'll talk about surgery. Is it needed? Well, this landmark study in 2018 clarified just this. So this study was pretty amazing. It was a randomized controlled trial with placebo controlled. Now this was over 30 different hospitals and 50 different surgeries, and they had 3 different groups. The first group was subacromial decompression. The second group is they had surgery, but nothing actually was removed. It was a SAM surgery. And the last group was no treatment at all or a controlled group. And what they found at 6 and 12-month follow-ups is there was no difference at all between the 2 surgical groups, and only slightly difference between the surgical groups and no treatment at all. However, it wasn't clinically significant. So this really puts a caveat on that the bone needs to be cut away for there to be successful outcomes. Thank you so much for watching our video today. Hopefully this provides some clarity on this very misunderstood topic. If you liked the video, please like it and subscribe to our channel and turn on notifications.